This talk is about diarrhoea and vomiting and how we manage it at the Princess Royal Emergency Department. This is a talk for all new doctors and nurses to the Princess Royal Emergency Department as part of their induction. The learning outcomes for this talk are to go through the GI bleed pathway and protocol, to look at how hyperemesis is managed in the emergency department, to go through some of the causes of diarrhoea and the infection control policies associated with this. The first thing, if a patient presents with a GI bleed, is to work out where they are bleeding from with the following symptoms. If they were to present with fresh red blood in their vomitus, where in the anatomy would they possibly be bleeding from? The same question goes as if this is coffee ground vomiting. If the patient presented with melena, where would you expect the bleed to have come from? And if on a rectal examination the patient has dark red blood, where would this indicate the bleeding is coming from? And if there is fresh red blood on that examination of their rectum, what are the likely causes of where this is coming from? So, looking at the fresh red vomitus, this is usually from a varicose or Mallory-Weiss tear. It normally occurs in the esophagus and has been a forceful vomitus up through the mouth. It doesn't tend to occur if the bleeding occurs in the stomach or lower in the gut. Coffee ground vomiting, on the other hand, does occur from the stomach or duodenal pathology, as the blood has been partially digested by the stomach's contents. Melena also means that the bleeding is in the stomach or duodenum, and this is because the blood products have been changed as they move through the bowel and out rectally. Dark red blood on a rectal examination indicates the bleeding is likely to be in the colon, whereas fresh red blood tends to be associated with a lower colonic pathology or indeed a rectal pathology, such as hemorrhoids or fissures. One of the next important points is to ascertain how much blood a patient has lost. This can actually be quite tricky to do in real life. Patients may bring you in the blood, you may see it on the patient or the bedding, or they may have photos of what they have passed rectally. This slide shows you just how much blood can be associated with large bleeds. For example, a soaked sanitary towel is about 100 ml worth of blood, whereas a full kidney dish is 500 ml. If the blood is spilling off the patient and onto the floor on the bed, this is usually about 2,000 ml worth of blood. So being able to clarify with the patient just how much blood they think they have lost will give you an indication of how severe the bleed is. Looking at the GI bleed protocol, which can be found on the clinical guidance folder on all the computers in the emergency department. In brief, if you have an upper GI bleed, this will go to medicine if they are admitted and follow the upper GI bleed pathway. If there is a lower GI bleed, these bleeds get admitted under the surgical team. Looking at the GI bleed pathway, if you have a suspected upper GI bleed, the first thing to recognise is whether it's a varicose bleed. So a lot of fresh red blood coming out in the vomitus. If this is the case, give IV terlipressin 2 mg straight away, and then assess for signs of liver failure. All of these patients will need to be referred to the critical care and medical teams, and also will need to be discussed with the on-call GI consultant for possibility of an urgent endoscopy. These patients will also need to be cross-matched 4 units of red blood cells and fresh frozen plasma. For all other upper GI bleeds, please calculate the pre-endoscopy Rockall score, This is found on the bottom right-hand side of the GI bleed protocol. The Rockall score looks at 3 different categories and then makes a percentage mortality related to the score. If the Rockall score is 0, the patient can be discharged home if the haemoglobin is normal and there is no other clinical concerns. These patients will need to be discharged with a letter to the GP asking the GP to request an urgent endoscopy and given treatment with omeprazole BD. If the Rockall score of the patient is 1 to 2, they need to have a group and save sent, and then we need to refer to the medical team for admission. If the patient has a Rockall score of 3, these need to be referred to the medical team for admission. And if they are hemodynamically unstable, they will also need to be discussed with the GI consultant on call and also cross-matched for 4 units of red blood cells and FFP. If the patient has a score of 4 or above on the Rockall score, the emergency department needs to refer to critical care and the medical team and also the GI consultant, as well as cross-matching 4 units and FFP. We are now going to look at the hyperemesis pathway of the emergency department. Currently, in COVID times, this has changed so that all patients with hyperemesis are seen and admitted under the gynae team. In non-COVID times, when our clinical decision unit is open, we will be taking these patients with hyperemesis on the clinical decision unit. The most important thing is to take the history and examine the patient. Please ask about previous pregnancies, whether they've in their first pregnancy, whether they're having a twin pregnancy, whether they've had any previous hyperemesis, or whether they have any other symptoms, such as diarrhoea or abdominal pain. Please check the urine dip and the urine HCG and make sure both of these are documented. To make a diagnosis of hyperemesis, you need to confirm the pregnancy. They need to have at least 2 plus ketones in the urine and no alternative diagnosis, more likely than simple hyperemesis. Please remember, some of these patients won't be hyperemesis. They will have gastrointestinal disorders, or they may have a cholangitis or sepsis rather than hyperemesis. Patients with hyperemesis who cannot go to the clinical decision unit are those who are hemodynamically unstable. If they have an associated urinary tract infection, or any kind of abdominal pain or vaginal bleeding, or indeed if their electrolytes have a gross imbalance. Before the patient gets to CDU, if they are suitable, they need to have a cannula in situ. We need to have checked their blood sugar and corrected if it is low. And their urine dipstick needs to be documented in the notes. IV fluids, antiemetics, thiamine, folic acid all need to be prescribed, as well as their regular medications. Please don't forget to prescribe anything that they usually are on, as these patients can be in for 18 to 24 hours before they will improve, and we don't want to stop any of their usual regular medication unless it's required. The hyperemesis protocol shows you which fluids and how long the fluids need to be over for the first 20 hours, and then any subsequent bags to that. This is on the back of the CDU proforma and should be adhered to. The treatment of hyperemesis is also on the back of the CDU proforma. It shows which are the first and second line antiemetics, and also how much folic acid and thiamine need to be prescribed. Please stop any iron supplements, and please prescribe ranitidine or omeprazole if there are symptoms of gastritis. Please also remember to do a VT assessment on these patients. They are most likely to require enoxaparin and TED stockings. Please make sure these are prescribed, as obviously they are in a high-risk period for having a thromboembolism. The discharge criteria for hyperemesis The patient needs to be able to eat and drink. All their observations need to be normal. They need to have adequate medications to take home and a referral to the gynae unit for an ultrasound if they've not already had a scan during this pregnancy. There is a patient leaflet to give them on hyperemesis as well. Please note that the amount of ketones in their urine doesn't matter for discharge. As long as they are eating and drinking, they will clear their ketones. There are many causes of diarrhoea: inflammatory bowel disease, diverticulitis, laxatives, which patients have been taking for their constipation and then not realise they'll be causing the diarrhoea, or perhaps with patients with dementia, they don't realise they're on them. Overflow diarrhoea when our elderly patients are constipated. And we have a large population of people with chemotherapy. And this can cause significant diarrhoea, which causes significant disruption to the patient's life. There are the obvious infectious causes as well as colorectal cancer. Usually, inflammatory bowel disease are already known diagnoses. Occasionally, we will make a new diagnosis and they will need steroid medication. And if needs, intravenous needs admission. For gastroenteritis, please ask about other unwell contacts, a travel history, give anti-sickness, and if clinically dehydrated, give fluids. We don't usually need to do a school culture unless ongoing for over a week, and we can generally get these patients home. We only generally use antibiotics if they're septic. For suspicion of colorectal cancer, ask about systemic cancer symptoms, such as night sweats, weight loss. And if they're well, they can go home and have a 2-week wait appointment. You can fill this in on EPR. All new cases of diarrhoea and vomiting may be infectious, and all will need isolating in a cubicle with the door closed. Please inform the nurse in charge if the patient needs a side room, especially if they're going to be admitted. If the patient hasn't disclosed prior to you getting there that they are having diarrhoea, then please move them to a cubicle with the door closed by talking to the nurse in charge as soon as possible. Please wear gloves and aprons to see these patients, and don't use alcohol gel to wash your hands. Use soap and water. If unfortunately you get sick with diarrhoea, if you're at work, please go home and contact occupational health. They may ask you to provide a stool sample in an appointment. If you're at home, you need to attend your GP and provide a stool sample. The reason for this is to ensure that we don't have outbreaks of clusters of infectious diseases around the hospital. There will be a further Zoom meeting to clarify any questions you may have over this topic. In summary, we have been through the GI bleed protocol, the hyperemesis performer, the causes of diarrhoea, and good infection control.